me make sure everyone can see my screen. Watching the webinar. Then I've got a case to pull up here. We're going to start, first of all, everyone say hey to Randy. He's up in Seattle. He can hear us, but we can't hear him very well. So, go
Hi,
Randy.
Hey, Randy.
Woohoo. And I'm sure he's having a good time. The next thing I wanted to say is everybody a fan on Facebook? Because we're putting some cool posts on Facebook that are definitely worth checking out. So get on Facebook if you have a Facebook account. Find Neurosomatic Educators and become a fan. There's actually a video clip up that you can also link to and have your fans and clients want to check that out and maybe start some business for you. So definitely something worth participating in. I think we're both, I think Randy would agree, but we're both finding Facebook to be pretty valuable. Okay, our first case, we've got a guest participant, but Don Wheeler has thrown some charts at us. We're very excited about that. And some other images that I'll pull up, and you can see at the bottom of my screen, all of these images that we're going to pull up in a bit and have a good time with. So we'll run through the basics fairly quickly. Someone took a deep breath. Someone's breathing hard. So move our mics a little bit away from our face. And I want to just run through the basics real quick. Some of it's going to be obvious, but we'll run through the 4 questions. One is, does there appear to be a leg length inequality? Anybody or everybody?
Yes.
Yes. Anybody got to know?
Speak up. Don't be shy.
Does anybody got to know? No. Okay, good. Yeah, there appears to be a leg length inequality. So I'll just highlight that real quick. How about that? So there you go. And where would that leg length inequality appear to be? Right here. Oh, we got green today. Very exciting. The second question, fixations. How many fixations? And remember, Felicie, a fixation is defined as?
Okay. A fixation is something that remains when you go from standing to supine. So it's an aberration that remains when you go from standing to supine.
Great.
Is that right?
Yeah. How many do you have? How many do we see?
Okay. Starting at the okay. I see. The head tilt remains. The shoulder tilt remains. Okay. Going down. That seems to be what I see.
Yep. That seems to be everything. Anybody got anything else? No. Okay, good. Next. Kim.
Yes.
Okay, how many subtle proprioceptive mechanisms do you see?
Now, SPMs are where there's a switch as well as an addition, correct?
Right, they switch or they get worse.
Right.
Yeah.
see a right anterior rotation in the right shoulder.
Okay.
I see an obliquity switch from left to right.
Very good.
I see the iliac crest switch as well.
Right, the
ASIS.
ASIS.
Mm-hmm.
Great.
And the trochanter as well.
Oh,
Oh,
well,
go that far.
right, but we don't go that far. So. And the iliac crest, we don't. Don throws that in for extra stuff. So.
Okay.
Okay. So, anybody got any extras?
The knee?
Well, those are below. So remember, for the trochanter and down, we're using that only for what?
Leg length.
Leg length.
I see.
Right. Okay, good. And finally, is this person meeting the demands of the writing reflex? It's just me with my fancy mousing work.
A lot of colors today.
I know, green, yellow.
I like it.
It's springtime. Anybody meeting the demands?
Anybody?
Yep.
No.
Yes.
Yes, meeting the demands. No, not meeting the demands. Who said yes?
I did, Marion.
Marion. I thought that might be you. And they're meeting the demands because.
Well, you look at the ASIS and the temporal bones, and they're going in opposite.
Okay.
So that means
right.
they're meeting the demands. And the PSIS and the occiput, I assume, well, actually, maybe, is that line the occiput, or is there a temporal bone? Now that I'm looking closer, is that line the temporal bone or the occiput on the first one?
Don.
Maybe I don't know, because maybe there isn't a temporal bone.
Don? Hello, Don? He must have muted himself. Oh, there he is.
Yes, I did.
Okay, so is this the occiput, or
Yeah, that's the
Or the
occiput. Temporal bones match.
temporal bones are level?
Yeah.
Yeah. So the temporal bones are level. That's what he's telling us.
Okay, well then, so obviously then that still means they meet the demands of the writing reflex.
Right, because they go to balance and equilibrium, they still meet the demands of the writing reflex. Sorry, I'm laughing at my artwork. I'm on a roll. So good. So it appears that this person is meeting the demands of the writing reflex. Great. And this is the point at which I invite Don to run through a little bit of case history, because we have some other images. Go ahead.
Yeah, we do have some other images. Basically, and this client is actually sitting in for this webinar with us right now, Toy.
Oh, hey.
So welcome, Toy. And we basically we had come in with some pretty good pain in the knee, in the lateral part of the knee, on the right.
Okay.
And the right groin, and like a right sciatica.
Okay. And a sciatica. Okay.
Oh, actually, yeah, and that's you marked that right, because on the basically the right quads and adductors
Okay.
also were in pain.
We're in pain. Okay.
Mm-hmm.
So we had some quads and adductors were in pain. Woo! Come on, mouse. Get in there. Right. And then sciatic type sensations also. So
Yeah.
highlighter. There we go. So pain through here. as well.
Mm-hmm.
On the back
And
of the leg.
lateral right knee.
And the lateral right knee. Yeah, did that go all the way to the foot, or did it pretty much stop at the knee?
No, stops at the knee.
Stops at the knee. Okay.
And no back pain either.
Okay. Let's do this. I'm going to pull up the history. So, high school teacher, knee pain, and also a bulging disc, right? So, I'm going to pull up another image here. And Toy had also been diagnosed with a bulging disc. And you can see from this image probably the reason as to why. Especially if we highlight this zone right through here. Right through here, and then also here. So between L4, L5, and L5S1, you can see quite a bit of lordosis in the lumbar spine. Were there other symptoms that she presented with?
I think that's pretty much it. Mm-hmm.
Mm-hmm. Okay. Yeah, let's go back to the chart now. So I want to take a look at the writing reflex. There's one more question about the writing reflex that I overlooked in my excitement to get to films, because we love films so much. And that was in terms of the writing reflex, there's one dimension that we neglected to look at. And so as we're revisiting this question as to whether or not they're meeting the demands of the writing reflex. Renee, do you see something here?
Well, I said that they were meeting the demands.
You thought
No, they're not.
Oh,
No,
and
because
why
of the-
not?
Because of the inflare, the temporal bone is matching the inflare of the pelvis.
Exactly. So the Levitt reactor says that these two should go the opposite direction.
Yeah.
And they're going the same direction. So that would mean she was not meeting the demands of the writing reflex in that dimension. So good catch. Good catch. Extra dimension. Very good. All right. So, Don, when Toy came in, or Toy, if you want to jump in, did she come in with these films, or no?
No, we had them taken.
Okay, so you did the evaluation and said, hey, you need to go see my guy.
We needed a leg length anyways, and so we had them take a lateral as well.
Okay. How did she know about the bulging disc?
Because she had a MRI.
She had an MRI. Okay.
Yeah, and the MRI had the bulging disc plus I think a tear at, it seemed like L5S1 maybe.
Right. Was that one of the films I have here?
I think I sent you one.
Be this, no, face. There it is. All right.
There you go.
So I know this image is rotated, so everybody tilt your head. Because
I figured you'd flip that for us.
Let's see if I can figure out how to do it.
They took it with her laying face down. She was prone.
Yeah, see, it won't let me edit it, so for some reason. So she's prone, and this is the anterior. Here, I'll draw a little arrow in there. All right, this is anterior. I don't know. There we go. So the bulging disc is, where do you guys see it?
L4, between L4 and L5.
Between L4 and L5,
No?
which is right here, right?
Mm-hmm.
Is that the one you're looking at?
Yep.
Yep. And then there's another bulge as well, right here. And then there's actually a few more that exist. George, are you with me on audio yet? Not yet. Okay. And Derek. So there's another one here that's actually closer to the nerve than these two, because remember, the further down you go, the cauda equina is here, so not necessarily as much of an issue. But if you look at this one right here, that one's the closest to the nerve. So I'm gonna take the artwork away so you can get a closer look at that. It's actually closest to the spinal cord, but there's still space, right? There's still fluid in between. So probably not so much of an issue. You can also see where here the disc ruptured as well. But it went forward, so typically we're not as concerned about that. And then here you can see some space for the dura mater, the dural tube, kind of, and there's fluid in between the ligament and the body of the vertebra here, and that's what that's showing. So very good. And who remembers what kind of an exposure this is? It's very quiet. There's two kinds of exposures for MRI, right?
Uh-huh.
Okay. What are they? You have two options, right? T1,
T2.
T1 and T2. And in T2, fluid shows up as, fill in the blank. White. White. T2, it shows up as white, as light. So there's fluid here. And this is a T2 exposure. Okay. Very good. So we've got the disc bulge. Does that look like a major disc bulge? Or herniation?
No.
Yeah. Not really. It's not really effacing. It's, this one may be, but it's not really effacing the spinal cord itself. Now, maybe there's some other image that shows where this is bulging into a nerve root or something like that, so we can't say with 100% accuracy, but, it looks pretty minimal compared to some of the stuff that we've seen. Okay, so I've got a couple of x-rays. There's that one. And, okay, so here's the original x-ray. And Don, you want to weigh in here? And I'll point and do artwork.
Yeah, well, so basically we did the X-ray. We've got a new chiropractor here in town who's doing pretty decent for us, and so we marked across the top of the from the right, which is the superior head of the head of the femur, and across over to the left side, and then went down to the top, and you got 16 millimeters there. Just for kicks, I usually, once I've got the flexion disorder out, so that we've got the same flexion on both sides, then I'll also measure the base of the ischial tuberosity and at the top of the iliums, and look at the possibility of hemipelvis if it looks like there might be one.
Right.
And if the flexion is the same on both sides, then that's a pretty sure bet that there is. So in this case, yeah. And then just I also like to draw a line across the top of the sacrum to see how much the body's already trying to take out on its own. So you got like 16 millimeters of leg length, but you got less than half of that hasn't been taken out, which doesn't mean you don't want to do it. Just I like to see how much it's doing on its own.
Right.
And then I'll usually draw a line straight from the coccyx up, just for the sake of illustrating for the patient how far off it is.
Right.
So that's what we got.
And that's this line from here to here.
Right. And then I'll draw one that's straight up right through the pubic symphysis. Go straight up. That kind of gives them a better visual of how far up it is.
Nice. How much is this, the sacrum, the difference at the ala here?
Are you asking me?
At the top of the sacrum. So say 5 millimeters. I can't read it, so.
Yeah, and I don't have it up on the wall on a viewer, but I believe that was about right, yeah.
Yeah, about 5. Looks like a 5, so about 5 millimeters difference there. Okay, and then the obliquity, you can also see the obliquity as evidenced by the obturator foramen and the width of those, right? I don't know how well that's showing up. So the distance from there to there, there to there, or you could measure the distance for the coxal bone here, or the ilium. And so that was going to show up. That's going to show up there. You also have a line across the top here. Curious to know what this particular line is.
Which one is it?
This this top line here, and then there's a line here. So it's this line.
Oh yeah, I don't even remember why I put that one there necessarily.
Maybe the trochanter.
It could have been, yeah. It could have been that was
showing the trochanter.
Although I don't know. I actually.
Yeah, actually, it's probably the trochanter because there's another line here for the right trochanter.
Mm-hmm.
So it's probably the left trochanter. Okay. Mm-hmm. Just like to take a look at that. Anybody have any questions for Don?
Don, you were saying that, this is Kim, you were saying that you took the number, the bottom number is 16, and then you just for kicks went up to the top, and it's usually, did you say it's usually half? If you find a hemipelvis?
You able to speak up a little bit more, maybe?
So what she was asking was calculating the hemipelvis. And how do you go about calculating the hemipelvis?
Okay, what I do myself, and there again, it would not be accurate if like in the postural chart that we've just been looking at, I think the flexion on one side was 10 and the other was 20. So then that wouldn't mean a thing. But if you get them both to 10 and 10, or whatever it is, if they both got the same flexion, then you should be able to measure from top to bottom. And what I do is I have a clear T-square that I use for making the lines to begin with, and that T-square has both millimeters and inches, and so then I just use that. I'll set that at the base of the one ischial tuberosity and measure up to the top, and then I'll do the same thing on the other, and you'll notice at the top of both iliums there's a number there, which Jolene grabbed me the x-rays. I don't have the viewer, but one is 226 and one is 217, it looks like. So that would be like 9 millimeters difference in one side versus the other if I'm seeing this right on my without a viewer, but that's what it looks like. It's 217 and 226. So that would just tell you that we've got about a 9 millimeter difference in the iliums themselves, and so then you'd be looking at taking the appropriate measures for that as well.
Right.
Okay.
Also, in looking at the x-ray and then looking at the flexion numbers, the 10 and 20 degrees, that's going to make up a big difference, and that will, to a great degree, account for the, this 5 millimeter difference that we see here at the top of the sacrum. So our body's really flexing to try and make up that difference.
Okay. Thank you.
Thank you. Any other questions?
And I'm not
Mr.
sure.
Don?
I did send you a second postural analysis, didn't I, Tracy?
There were two charts. Not for Toy, no.
Okay. Well, on Toy, before I sent her in, I got the flexion within a degree or two of each other. So otherwise, the measurements from the ischium or the ischial tuberosity to the top of the elm would be meaningless as far as hemipelvis.
Right.
But if they're the same, then that's a pretty good indicator.
Right. So now this is a follow-up film that she also had an arch collapsing. Is that correct?
I believe that's right. Yeah.
Yeah.
Yes.
So this is a follow-up film that was shot with the lift, correct?
Correct. With the lift and arch support both.
Lift and an arch support. So you can see it gets her femur heads level, the sacrum is level, and then there's just a small difference at the pelvis here. So good. That's really, shows. And look at the difference in her spine, right, from one film to the other with putting the lift. So look at how appreciable the angle is there as it tilts off to the left. And then the difference here with just wearing a lift. So do you have any more comments for this, Don?
Okay, well, here's where we're at.
Okay.
We've gotten rid of the sciatic pain virtually altogether. We've gotten rid of the groin pain. We've gotten rid of basically all of the anterior work on as far as the quads and all that. What we haven't got is the lateral knee stuff, and that little sucker does not want to go away. So if anybody's got any thoughts or comments on that, I'd love to have them.
Tracy, could you put up the posturology chart, please?
Sure.
Thanks.
You're welcome. And it's the right lateral knee pain that endures.
Correct.
Anybody got any ideas?
He says that it can go across the whole knee. It doesn't just have to be lateral. It's always lateral, but sometimes it takes in the whole knee.
Do we have a current chart? By any chance?
Are you saying do you have one, or do I have one that I could
Do you have
send
one?
you somehow?
Do you have one handy? No, that's not the one I'm looking for.
No, that's not Toy. That's somebody
No,
else.
that's somebody else.
That's somebody else.
Yeah. Okay.
Yeah, I had thought I sent you one that was current, but I guess.
Yeah, I didn't. I just got the one.
Sorry.
Oops. Okay, so, but currently, if we were to draw it in, what kind of distortions would you see?
Okay, let me just pull a current chart here. Okay, our flexion is actually around 5 to 7 degrees on both sides.
Okay.
We actually currently still do have some rotation in the right hip anterior.
Okay, so the hip rotation remains.
Mm-hmm.
Probably not that big,
About 1.5 inches. But both sides are forward. I actually have it measured pretty precisely. The left hip is 1.5 inches forward of where it should be, and the right is 3 inches forward of where it should be.
Okay. So she's still projecting.
Yeah, some.
Yeah.
Yep.
And then, do her knees hyperextend?
No, her left one is dead on the money, and her right one is about 1/2 inch forward.
Okay.
So, nope.
And the pain is not patellar tendon or patellar ligament, from what you can tell.
As far as I can tell, no.
Right.
And you did IT band stuff already done?
Yeah, he didn't hear. Kim volunteered. Did you do the IT band stuff?
Well, yeah, I have. a couple of times. Actually, Tori, didn't you say that seemed to actually kind of irritate it when we did the sideline stretching and all that stuff?
It did when you stretch the side.
Mm-hmm.
Yeah, she said that seemed to actually make it worse.
That actually seemed to make it worse.
Before the stretching, though, did you do any cross-fiber friction?
Well, yeah.
Yeah.
Manual treatment. Good. How about? Go ahead.
What about organ work?
What about what?
Organ.
What about organ work? If you've tried the muscles and that hasn't worked.
No, we've done a lot of visceral work too.
Okay.
That was a good part of getting rid of some of the other stuff in the back.
Sure.
And what about the hamstrings up into the ischial tuberosity up around the sits bones? Like some stripping or active release?
Yeah, the hamstring. Yeah, I'm not sure if how well Don can hear you, so I'm repeating.
Oh, thank you.
Yep. So, how about the hamstrings, especially at the ischial tuberosity?
Yeah, no, I'm thinking we've worked that awfully thoroughly too.
Right.
And then my last thought was,
Please.
I'm sorry, was the rectus femoris, the insertion up there.
The insertion of rectus femoris.
Into the hip, yeah.
Right.
Kind of into the hip flexor area.
Especially where the insertion is.
All right.
Yeah.
Yeah, no, I've hit it, but at that I don't really know exactly any particular reason other than it's an insertion site, but otherwise, where her knee is basically directly above her ankle.
Yeah, here's the key. Here's the key, and Randy was all over this, and but what the one distortion that remains in the pelvis is fill in the blank. The right hip goes anterior. So what are muscles that could drive the right hip anterior? The glutes, right? Marion, do you have an opinion here?
Well, that's what I was going to say was the glutes.
Glutes.
As well, and also I would have thought the hamstrings would have driven it forward too. But
right. Well, we treated the hamstring, so we got that.
What about the adductor magnus? Because that also attaches, acts as a hamstring.
Right. That could definitely be a player. So
it was a big player in the groin pain. Adductor Magnus, that was a major one there. But we've treated it down to the point now where it's typically not even tender anymore.
Right. Here's the key, though. There's one thing that would cause both a projection and a lateral knee pain.
How about the deep hip rotators?
Close, but they would cause the projection, but specifically relating to the IT band. So I think Kim was right when we were going, tracking the IT band.
Sartorius and TFL?
Well, the TFL is one factor, right? But there's another muscle that attaches to the IT band.
The vastus lateralis.
But it also causes projection of the pelvis. And the fact that the stretching irritated it.
I only think it's sartorius.
Gluteus medius.
All right. Do I hear a gluteus maximus? So the gluteus maximus has fibers that attach on the iliotibial band. Sorry, I'm having fun with Randy. The gluteus maximus has fibers that attach on the iliotibial band. So when he did the stretching and the gluteus maximus didn't necessarily release, then those fibers that attach on the IT band and or the TFL, and that caused kind of the lateral knee pain, the iliotibial band, lateral knee pain. So aside from if we're looking at muscle tissue, those are the most logical.
Mm-hmm.
Because the stretching irritated it, and the gluteus maximus didn't totally release, and that could have irritated it. So we're looking at potentially IT band. So the question is it the lateral tibia that's hurting? Right, the lateral part of the head of the tibia, just anterior to the fibular head.
Mm-hmm. That's what it seemed like, yeah.
Right, or is it actually at the fibular head, or is it actually in the knee joint? And by ferreting out those three things, that's going to give us the most logical progression. So by ferreting out those three, if it's at the fibular head, what is it likely to be? Renee, you got it? What's the muscle that attaches at the fibular head? That could also cause projection. Pass. It inserts at the fibular head. Anyone? The biceps femoris. The biceps femoris inserts at the fibular head. So that's, I got that, someone just woke up. The biceps femoris inserts at the fibular head, and so that could be causing that lateral knee pain and also causing the projection. So we've got a couple of different muscles to look at. And then the next thing to look at is the either the knee ligaments themselves or the knee cartilage. And those are, for most of us, that's a little out of our territory. So those are other possibilities that somewhere along the way those got strained or injured. But with the right leg being the longer leg, that's leading me to look at something with the IT band. And the other thing we knew about Toy is she's pretty active, right, Don?
Yeah, she is active.
Yeah.
She was saying that when she's got to drive any distance at all, that accelerating, where she's pointing her toe forward, really shoots it to her pretty good. And that'll actually even have it go up the front of the leg.
Right. Right. Well, she's sitting on the gluteus maximus attachment at that point, and also on the hamstring, on the biceps femoris. So those are definitely two distinct possibilities, but definitely worth checking those out. Does that give you some new ideas or direction?
Well, it gives me a couple things to recheck at least.
Yeah, to go back and revisit. And then also to ferret out, is there potentially some ligament issue, especially with changing her posture so dramatically, with a 16 millimeter lift and an arch support. That's going to change her posture dramatically, and there could, her soft tissues, and specifically the ligaments and tendons have to change. So what law is that? Where soft tissues and ligaments change?
And Toy wants to know how long that's going to take too.
Yeah, and how long does that take? Anybody? Is that Ivani? I think just about everyone went mute just now, and I don't know. I don't know why. Okay. Ivani. Did you go mute? Because your hand's up and I can't hear you. Derek's got his hand up. Derek, send me a question, and then I'll be able to see your comments. All right, so lost my track.
What law?
Yeah, what law? Thank you. Ivani knows what it is, but she can't communicate it to me for some reason. So I'll just throw it out there. So it's not Wolff's law, because that's the law of bone transformation. So Davis's law is the law that says that if you put a...
Hello.
Oh, there you are.
Oh, can you
Ivani.
hear me?
Yeah. Throw it out there.
Okay.
What do you think it is?
Well, I think I got it wrong. I said Hilton's law.
Hilton's law. Okay, well, the nerve that supplies the joint supplies the muscles over the joint. It could be Hilton's law. But Davis's law is the one that says that if you stretch a muscle, then the body will add sarcomeres. If you shorten a muscle for an extended period of time, the body will take away sarcomeres. And depending on if it's a tendon, that's going to take longer to change. A ligament's going to take longer to change even than a tendon. So if it's something like that, that's something that could take some time. So we definitely want to look through and just re-examine those tendon attachments and the ligaments as well, and treat those to see if you can improve the circulation, because those may be strained, especially that head of the fibula. Those ligaments could actually be getting stretched, because if this is the on the longer leg side, typically what would happen is an arch collapsing, which is going to take the head of the fibula and drive it up. And then when you correct the posture with the lift, then what happens is it creates a downward pull. And since she's had that for 50 plus years, more than likely, then those ligaments are going to have to change back again. They're going to have to lengthen, and those are going to complain a lot as well. The caveat, though, and the thing that leads us to the TFL attachments for gluteus maximus, is that she had this pain before, and that's pretty much what brought her in. So that's why we pretty much jump on IT band and TFL issues. So, okie doke. Any more questions or comments for Don?
Toy says, don't be bashful if you got any ideas.
Yeah.
I have a question. If you used heat on the knee, like a heating pad, would that help with the pain?
So have you tried that, Don? Have you tried any other thermal therapies or?
We've gone with heat and cold. Either way, it doesn't seem to influence that too much. But we have tried both.
Right. And Derek, I saw you thought Hilton's law, so thank you. Cool. Wow, what time is it?
Oh, you know what? I do have a thought, actually.
Yes.
When she's sitting in the car, does she have a bucket seat?
So does she? And what kind of seats do you have in your car, Toy?
Honda Accord.
Honda Accord, buckets.
Yeah.
Yeah, bucket.
Yeah, bucket seats. Yeah.
And so, do you have like a smaller towel kind of rolled up to try to put the pelvis into to help the spine in that kind of position versus kind of slumping down and sitting on that glute?
Right. So in the way she sits in the car, would it be possible to, correct me if I'm wrong, Kim, increase the lumbar curve or support the lumbar curve?
Yeah, give some support to the lumbar curve, but more kind of put the towel roll under the sits bones, and it kind of keeps the pelvis in a more anterior position, and it's less likely for the person to slump back.
Did you get that, Don?
Yeah, I did. And I guess she has not got a lift, an issue lift in the seat of her car. Mm-hmm. Do you notice that you sit up on one side a little bit more than the other? Because that's what a lot of times they'll do if they got a Hemius.
Right.
They'll automatically gravitate to the high side of the seat.
Yeah. Randy wants to know how much does she drive?
How much do you drive?
I drive 25 miles to work, back and forth each day.
Yeah, so 50,
Here, yeah,
50 miles a day to work and then
35 to
35 to her therapist.
Right. Does that take you an hour, 40 minutes?
30 minutes.
30 minutes?
So, yeah, 30 minutes each way.
30 minutes each way.
Yeah.
Mm-hmm.
And then the knee pain, that aggravates the knee pain, does it endure for 10 steps, 2 hours?
It doesn't never, but it doesn't necessarily aggravate the muscle. It aggravates the muscle when I accelerate. It goes straight up to the thigh.
So
Right.
she's saying it aggravates her quad when she's accelerating.
It aggravates
It's aggravated more when I walk around in my classroom and bend over desk.
And bending over desk, she's a
Right.
teacher, school teacher, so.
Right.
bending over desk.
So accelerating causes pain on the front of the knee or the back of the knee?
No, across the top of the thigh.
Across the top of the thigh is what she says.
Across the top of the thigh. And the standing aggravated. These are questions from Randy. So,
Mm-hmm.
so it's just standing aggravate the knee?
The standing aggravated.
Like if you stand still as opposed to moving around?
The sitting worse.
At times.
Yeah.
Nothing's consistent. And
Yeah, it's not real consistent, but standing doesn't seem to be the big problem.
Okay.
Sitting or bending over, either sitting or bending over a student's desk seems to be the two things that get it most.
Right. Okay. Right. So, and it's the quadricep.
Mm-hmm.
That's the issue. So it's still, like Randy says, still focus on what's causing the rotation and projection.
Mm-hmm. Mm-hmm.
Because I think that's, probably still the area where that's coming in. All right. So there is an aside question. If there was any issue with the atlas since the head was tilted.
No. I don't remember ever having a problem with the atlas. Jolene saw her first, and she said, oh yeah, okay, I've got Jolene's thing here. Sure enough, it was what would be a left rotation on C1.
Okay.
But she fixed that before she ever sent her my way. So I never saw one.
Gotcha. And then just as far as a protocol, did you get the x-ray first, or did you do a treatment first and try to get the iliums balanced and then get the x-ray?
Yeah, no, I did a couple of treatments first, and then but just a couple, just enough to, and the flexion came together real easily, so we got them within a couple of degrees of each other and sent her in. So she only had probably a couple of treatments, 2 or 3 treatments before she got her x-ray.
Very good.
And then ran straight out and got her shoes built up.
Awesome. And that makes all the difference.
Mm-hmm.
Are there any other distortions on the current chart other than the projection of the pelvis?
I was thinking of the obliquity. Was that addressed?
Yeah. Yeah, I don't say any obliquity anymore. We've got the right ilium anterior a little more than the left. Actually, the right shoulder is a little anterior too, but it's minimal. It's actually gone where the left one is behind the coronal plane a little bit. So you do have about 1.5 inches, 1 3/4 difference from side to side, but it's the left one that's posterior more, or at least as much as the right one being anterior. So just, and it's kind of splitting hairs because you're talking 3/4 of an inch one way or the other.
Right.
Other than that,
how about cranial measurements?
Cranial's good. Her right shoulder is slightly superior to the left.
Okay.
Still, which is kind of still a bit of a fixation, basically from the get-go.
Yeah. Now, is she right or left-handed?
Left-handed.
Left.
And then working on the computer, does she work with her right or left hand on the mouse?
Right.
Right hand on the mouse. Does she carry a laptop?
But she doesn't do a whole lot of computer work anyways.
Oh, okay.
She hand grades those things.
All right. Well, that would explain quite a bit. I don't really think we have too many other questions on that. Near as I can tell. Has anything ever worked and then the pain just keeps coming back, or?
Everything else seems to have pretty well, we've gotten most everything else gone. It's primarily just this knee thing. And yeah, some of them, yeah, definitely. Some of them are days are a lot better than others.
Okay.
But we can't seem to get rid of it altogether and keep it going.
Right.
Is there any truth when front's coming that hair tight?
Yes, because it's probably the changing weather. However,
there's also... Go ahead.
Go ahead.
She did have...
I was going to say she just started some water work, so
okay.
That may be the trick.
The trick. How about pelvic mobilization?
Yeah, no, we've done it. In fact, she has that for homework. She does good with it.
Okay. Great. Just trying to clean up a little mess here. Yeah, I was thinking contrasting might be a viable short-term treatment as well, just to get a lot of blood in there.
So you're talking heat and ice?
Yeah, heat and ice. Alternating to try and help out with that. Awesome. Well, that's a cool case. I'm pretty excited, and there's some potential practical applications there. But yeah, I think
appreciate the input.
Yeah, I think some key areas are the ligaments and tendons in the area, potentially knee cartilage issue. So we haven't seen any films of the knee or X-rays of the knee or anything. But the more logical stuff are the ligaments, the tendon attachments, and the muscles that attach to those. So very good, exciting. Great. Any other comments or questions from any of the participants? From you, Don?
Only appreciate the input. Thank you very much.
Excellent. Excellent. Well, and we figured out a lot. And you solved a lot of problems. I mean, you took somebody who was, it sounded like she was suffering quite a bit to really making a difference. So if, Toy, if you were a 10 when you came in, like 10 was the most pain, where would you say you were now?
That probably depends on the day, but most of the time I would probably put it more at 2 or 3.
At a 2 or 3.
Irritating.
Right.
I'd like to be a 0.
And there's so much we could say.
There you go. She would like to have 0 pain and not much attention paid to her knee at all. Awesome. Thank you. That's really pretty cool. I just want to do a preview of this, if you don't mind, real quick. And thanks, Don, from Derek Oliver, for to let you know. But I just wanted to
You're welcome, Derek.
Throw up this picture there, a preview for a future case, perhaps. So that'll be one that will be quite interesting and follow up on. How many times have you seen this young woman? Don?
Sorry, I missed it. What was it?
How many times have you seen this young woman?
Not many. We'll say maybe 4.
Maybe 4. Okay, so maybe in like another month or 2, you might have more of a history.
Yeah, definitely. There's not much of a history there. The thing that I'm kind of anxious to figure out is if you look at the MRIs, X-rays that I sent you, the L5 is not developed properly.
Right.
And all of the doctors that she's seen, and she's seen a bunch of them, all are calling it idiopathic.
Right.
But she's up to this, the X-rays, MRI, well, the MRIs that I sent are, I don't know how old, several months at least. She's gone clear up to a 62-degree curvature now, which is a lot, and, getting worse fast. And they are wanting to do, well, they don't call them Harrington rods anymore, but they're wanting to put rods in her back. The mama's already got them and doesn't want them for the kid.
Right.
But with that distorted disc, that's going to be the trick, is what the world to do about that thing.
Yeah, interesting.
That's the primary, I think, on this thing, although she does have a leg length, and she did
have it's a teaser, Don. It's a teaser. We'll see what happens in the future.
Sorry. Hey, where'd you get volume from, Randy?
Speaking of teasing.
Oh. Okay, fine.
So this is our case for today, just to wrap up. And I just want to say, everyone, thanks for coming and checking out. And we had a little technical glitch getting the invite set out on our email account, but things seem to be working pretty well. I'll send them out. Also, if you're in the neighborhood, I think in June is the World Massage Festival. As Randy's pointing out to us, the World Massage Festival, which will be in
Berea, Kentucky, June 17th to the 21st.
In Kentucky from June 17th to the 21st. And I believe we have a link on our webpage where the schedule is. So definitely something you guys might have fun with and check out. And I'm going to camp out here and send out copies of past webinars for everyone. And hopefully the formats for getting these in will be functional. So we can look forward to those. I hope you all are having a wonderful time, and your practices are surely growing as you get smarter and smarter and better and better trained. The reason why you want to go to the World Massage Festival, Don, why are you going to the World Massage Festival?
Well, I've heard that the keynote speaker will be Paul St. John, this guy that's pretty well known for good stuff. And I've heard that Saturday and Sunday he will be teaching 8 hours a day, Saturday and Sunday, his new water work techniques called aquasomatics.
Aquasomatic therapy.
I don't think that there would be any way that you could keep me from not being there. In fact, we're bringing our entire crew, everybody.
Bringing the whole crew for the aquatic, the aquasomatic therapy. So that's pretty exciting as Paul continues to push the envelope with our field, and we're excited to be affiliated, and we're hopefully going to have some new tools available for you, so that should be pretty exciting as well as things are coming together. And I hope we can all get our little technical bugs and glitches. I know some of us didn't have audio tonight, so that's a little trying, but we do the best we can. We have the best students in the whole wide world, and we appreciate that. We have a lot of fun doing these. I know I'm speaking for Randy at the moment because maybe he can't type fast enough, but we definitely are grateful and excited to get to work with you guys every month on these webinars and to hear the quality of the suggestions and questions that crop up. It's pretty exciting, so you guys should all feel pretty good about yourselves. And then just a quick reminder to follow up and get on Facebook and communicate with us on Facebook and pay attention to what people are doing. Again, we find that to be a valuable tool. So look at that, take a look at that, communicate with your own clients, customers, potential clients as a tool. All right, thanks so much, everyone. Have a good night.
Thank you.
Good night.
Thank you.
Night.
Talk to you later.
Good night.